Thank you all for being here. My name is Doshani. I'm a medical epidemiologist at the Division of Viral Hepatitis at the Center for Disease Control and Prevention, and I will be moderating this session today. Some of the work I've been involved in is to provide technical assistance to support state and local health departments in their Hep C elimination efforts. And I've also worked with the ACIP hepatitis work group and led the homelessness as an indication for a Hep A vaccination study, which is now a recommendation, and currently working on efforts to scale up implementation of the integrated hepatitis B screening and vaccination guidelines and the hepatitis C recommendations in high impact settings. I'm joined here with my colleague, Jasmine West, who will be co-moderating this session along with me today. Jasmine is a manager on the hepatitis team at NASTAD and is the lead on the CDC-funded award, the Hepatitis Network for Education and Testing, the HepNet. She oversees programmatic initiatives working with clinical providers, people with lived experience, syringe service programs, and harm reduction programs to provide training and technical assistance to identify and address the unmet needs of people who inject drugs. Jasmine supports state health departments and community partner technical assistance requests to improve access to viral hepatitis education, prevention, testing, and linkage to care and treatment for priority populations. This session will focus on federally qualified health centers, FQHCs. FQHCs play a very crucial role in testing, treatment, and management of hepatitis C in the United States. And these community health centers serve underserved and vulnerable populations, providing a wide range of services, including hepatitis C diagnosis and treatment. Their unique ability to provide a comprehensive and patient-centered care makes them invaluable in the fight against eliminating hepatitis C and its associated disparities. Today, we have a group of dedicated experts who will be sharing their valuable expertise and experiences in providing hepatitis C care in these community health centers, and they will share some of the barriers and successes they have encountered. Following the three presentations, there will be a Q&A session, so please add your questions in the Q&A box, and we hope to have a robust discussion with the help of our speakers and our mezzanine subject matter experts that we have invited to participate at this convening. So the first speaker I would like to introduce is Dr. Andy Seaman. Dr. Andy Seaman is an associate professor of medicine at the Oregon Health and Science University, the medical director of hepatitis and HIV services at Portland, Oregon's Central City Concern, and he's the director of substance use disorder services at Better Life Partners, which is a harm reduction-based opioid use disorder treatment program. He's both certified in internal medicine and addiction medicine. He's a harm reductionist, educator, researcher, and an activist for substance decriminalization, overdose prevention sites, and the rights of people who use drugs. His research centers on the intersection of hepatitis C and injection drug use and the implementation of harm reduction into health systems. The second speaker on the panel is Dr. Stacey Trooskin. Dr. Stacey is a faculty member of the Infectious Disease Division at the University of Pennsylvania Perelman School of Medicine and is the executive medical officer of the Mazzoni Center in Philadelphia. Dr. Trooskin received her MPH in public health from Yale University, her PhD in epidemiology from Rutgers School of Public Health, and her MD from the University of Medicine and Dentistry from New Jersey at the Robert Wood Johnson School of Medicine. She has served as a member of the American Association of the Study of Liver Diseases and Infectious Disease Society of the America's HCV Treatment Guidance Panel and currently serves as the medical director for C-Change, a technical assistance program of the Health Federation of Philadelphia, as well as the medical advisor to the National Viral Hepatitis Roundtable. And finally, our last speaker in the panel is Dr. Stephanie Constantino. Dr. Stephanie is a family medicine physician who is board certified in addiction medicine. She received her medical degree from the University of Washington School of Medicine. She's a core faculty and alumni of the Family Health Centers of San Diego Family Medicine Residency Program based in an urban FQHC. As a chief resident, she's completed the HIV track and championed universal buprenorphine training and addiction medicine curriculum. Her practice includes HIV, hepatitis C, addiction medicine, LGBTQ, health, prenatal care, and reproductive health. She's part of the mobile medical unit street outreach team that partners with Syringe Exchange to provide rapid screening and treatment for hepatitis C. Our professional interest also includes increased diversity in the healthcare workforce, health equity, and trauma-informed care. Now I will pass it on to Dr. Seaman to begin his presentation. Thank you very much.
Thank you so much. It was a great introduction. I will share my slides now. If I could get a quick thumbs up, you can see that. And I'm going to expand them. Great. So yes, thank you. I'm Andy Seaman. I'm coming from Vermont. The work I'll be describing is in my work in Oregon. And I'm going to be talking about how do you harness the power of microelimination models and sort of build outwards towards community partnerships and other ways of thinking about elimination in broader and broader senses. And I look forward to it. These are my disclosures. So we're going to talk about the journey that we had at Central City Concern in building our Hep C elimination program, thinking about how do we start out with very small microelimination models and kind of build outwards towards macroelimination. And then really, I love talking about kind of non-traditional things like the role of love and harm reduction philosophy and interconnectedness in Hep C elimination and how we can do that in the FQHC setting. So this is where we are. This is Oregon.
Andy,
yes.
Actually, I don't think that we can see you forwarding screens or slides.
Can y'all see? I am looking at a slide here that says shows the state of Oregon. Are you not seeing that?
No. Will you please try screen sharing again?
Yes.
Thank you.
All right.
Yes, state of Oregon, all you.
Okay, if this happens again, I'll just revert to you. So if you want to follow along on your side, and I'll have you share your screen and we'll go from there. Does that sound good?
Yes, thank you.
Thanks. All right, so this is a map of the state of Oregon. It shows the prevalence as of 2018 of hepatitis C in Oregon. Darker means a higher prevalence. And then here is the Portland metro area. And we have a population of about half the size of the state population, and that's where Central City Concern is. Oregon has the third highest Hep C associated mortality and the fourth highest Hep C prevalence in the country. Next, I moved to my next slide. Let me know if it doesn't change. We are a houselessness services organization. We serve about 14,000 Portlanders, although the Hep C elimination program I'll describe as larger than that. We have supportive housing, including low barrier housing, transitional permanent housing. We have a residential detox center, some culturally specific services, as well as a couple of different FQHC centers and a Hep C clinical pharmacy services. So we began treatment of hepatitis C at Old Town Clinic, which is our flagship clinic, in 2017. We just began to see people who had cirrhosis, Hep C, who were referred to specialty settings and just weren't being treated. And we started with just a lot of energy, a couple of providers, and a lot of anger and love for the folks we were serving. And in 2017 in Oregon, we had some of the worst Medicaid restrictions in the country. You had to have cirrhosis. You had to have no substance use at all. Only specialists could treat hepatitis C. And so we started a brief study, got some funding from a pharmaceutical company just so we could get free medications for people who couldn't access treatment. And we did a qualitative study, and we found that the people who we were treating, the small group of people we treated who weren't able to access treatment otherwise, who were actively using drugs, they reported more self-efficacy, less chaotic substance use, more harm reduction, services engagement, and better relationships with people in their lives. And really for us, this is where we became inspired. This is about so much more than the virus. These viruses, hepatitis C is this endogenous reminder of all of these highly stigmatized situations that people have found themselves in where they end up contracting hepatitis C. People who inject drugs don't get Hep C. People who inject drugs who are in highly compromised situations get hepatitis C. And so this was about far more than the virus, and it really inspired us. So we started small. We started with this primary care clinic setting of 4,000 people. We first started screening just at-risk patients. So you're going to see a lot of these care cascades. I like to use this just to show kind of how we make these little interventions over time. So at the time, we were just trying to identify and screen at-risk patients. This was folks in between February 2017 and December of 2018. We did risk-based screening with a 34% PCR positivity rate. Only 41% of these folks initiated treatment in part due to the prior auth restrictions, and had a very high SVR12 completion rate, showing that the people we were able to get into treatment were highly motivated. We identified that we needed to move from risk-based to universal screening, and we decided to build some systems into bottlenecks within our clinic. And then we decided to figure out how could we streamline the referral process and mitigate and organize against prior authorization barriers. So we developed, back one slide, we developed some systems so that every person who came in and had medications ordered, or every person who came in who had hepatitis C were pre-reviewed by providers quickly so that they could write a prescription for the medications and get the prior auth approval before they were seen, so that when you did bump into them next, we could just give them medications. It's absolutely critical in this process to be able to hand people medications as soon as you see them. And we really organized and rallied against the prior authorization criteria. We also began to build internally and we refined some systems. So we added a clinic site. There was a Blackburn clinic that was opened, and we started doing universal screening at that point. So at this point, both the Blackburn clinic and the Old Town clinic, everyone who came into the clinic and completed an intake to services were offered screening with a new lab algorithm that we developed. It was a one-click lab algorithm that you screened for Hep C, Hep B, and HIV, and then it completed the full pretreatment algorithm. And that both increased the number of people that we screened. Then the percentage of those who we screened in our entire clinic went from 31% to 46%. But we still had this huge group of folks who were already within our system that was harder to find ways to make sure everyone got through. We also decreased treatment barriers. So we fought hard against the prior auth restrictions. We're able to slowly over time get them down to no fibrosis restrictions. We're able to treat people who were engaged in some substance use treatment, and eventually remove the requirement for substance use disorder treatment and got rid of the specialty requirements. And then, as it says here, we created this one-click screening algorithm, which you can read about in the International Journal of Drug Policy. And we did notice at that point a change in our SVR12 completion rates. So the number of people who came in who were treated, we had a very high initiation rate among those who were positive, and a high treatment completion rate not shown here, but the number of people who were returning our SVR12 completion, or for SVR12 labs, started to go down, which to us showed us that we were starting to treat a more complex population. So for us, that was a good thing in many ways. So I'm going to fast forward now all the way to this is the data showing the entirety of our program from February 2017 through March 2023. We have, of all unique patients who have ever been exposed to anyone in our health system, we now have, we have approached almost all of them for screening. And a lot of this has been through interconnectedness and new partnerships. So because we have housing, because we have a detox center or medically supported withdrawal center, because we have multiple different clinics, and we also have our fingers out now into 5 different opioid treatment programs, dozens of street outreach sites. We're kind of everywhere within the Portland metro area. We are able to, if we miss someone at one point, we can catch them in another point. So that interconnectedness is absolutely key, not just for screening, but for everywhere along the care cascade. You can see that we still aren't screening everyone. So of those who we've approached, we have about 62% who were screened. And again, I attribute a lot of that to the interconnectivity and to our Hep C team, which I'll introduce later. But many of these folks who have not been screened were either not appropriate for screening within our system, like they've just been screened elsewhere, or they didn't have any risk factors, or for other reasons. So most people who should have been screened now have been screened in this web. And we also implemented financial incentives, so $15 incentives for screening, $10 incentives for referring people into screening in our outreach settings. And I think really importantly, we implemented dry blood spot testing back in 2020. And I'll talk more about that. So we developed a dried blood spot test with a lab called Molecular Testing Labs. We validated the hepatitis C RNA, and they already had the hep B surface antigen, HIV, and hep C antibody. And we also validated this hepatitis B core antibody on something very similar called the serum separator card. The idea of this back when we started this validation in 2018 was that this is what we felt comfortable treating people with just these data without any fibrosis score, as long as we could figure out how to risk stratify those folks. And so the benefit of dried blood spot is we can do this in the community. Anyone can do the test. It's a finger stick test, so people who inject drugs and people who may have somewhat traumatized veins have a much higher acceptance rate of dried blood spot. And we can diagnose people from within our FQHC sort of milieu, but not physically within the building. So we're doing this out in the street, and we could do confirmatory testing. It's been a real sea change for us. And so what we're doing here is that we, in addition to now screening people in kind of distributed ways through dried blood spot and sometimes point of care testing, we now have been able to, now we got rid of the prior authorization in Oregon back at the beginning of 2023. Now that we aren't required to do fibrosis testing on everyone, we have been able to figure out a way to actually treat people with just dried blood spot and serum separator cards. So the vast majority of people who have ever been exposed to our system now have been treated. We've gone up to 86% of anyone who's ever had a positive RNA in our system has been treated. Some of that, I would say not most of it, but some of it is attributable, I think, to this this dried blood spot test and treat model that we developed in the D-check questionnaire, which I'll talk about in a minute. But a lot of this really is just the interconnectedness, the harm reduction values of our team, and how we just continue to be able to run into people over time. And I'll show you another graph that talks about that in a minute. But briefly, and this is just like an intro to this, we had to figure out, in order to do this DBS test and treat model, we had to figure out how do we risk stratify out these people who may have decompensated cirrhosis. You know, when we all started this, for those of you who were treating back, you know, in 2017 and before, you had to really figure out what their fibrosis score was and whether they had cirrhosis in order to figure out your regimen. That's no longer true. All you really need to determine now is, do they have decompensated cirrhosis or do they not have decompensated cirrhosis? Still very important to know whether they have compensated cirrhosis or not in order to determine their liver care. But as far as hep C treatment goes, you really just need decompensated or not decompensated. So we developed a questionnaire. We validated it against 1,746 people who we had treated at that point within our system, including 35 who had decompensated cirrhosis and 131 randomized controls within our setting. And we scored them based off questions around alcohol use, prior liver disease complications, and so on. And we found that people who had a D-check score greater than 100% or greater than 8, that cutoff had 100% sensitivity to detect decompensated cirrhosis, as did a D-check score of greater than 11, not surprisingly. And so we are now able to implement this within our system to say, we can ask these questions, these 4 questions, and using those 4 questions, we can say, I feel very comfortable treating people, making a medication treatment decision based off only this score, and to determine whether or not someone does or does not need additional lab work prior to treatment initiation. Someone sees someone in the community or in an opioid treatment program or on the street, they do the dried blood spot serum separator cards, they do a D-check score, and they start them on DEAs. They never have to walk into our clinic at all. So that's been a real game changer as well, and we'll share data once we have outcomes data with that. And then finally, we've been really working on increasing our SPR12 treatment completion rates. So we have now gotten that SPR12 test completion to 72%, and we still have a very, very low treatment failure. Some of this is now we're using DBS cards for SPR12 lab completion as well. I think this is the last brief graph I'm going to show you. So this looks at this top kind of yellowish line here is the treatment initiation rate ever. This darker green line is the treatment initiation rate in the first 60 days. So who do we get in for treatment quickly? And this blue rate is PCR positivity rate of all people who are screened. What you can see is early on in our program, we had a very low initial or early treatment initiation rate that got better as the prior authorization went away and we developed some of our systems. But over time, this group of people, almost everyone who was identified early in our system got cured, and then that rate is going down. And that's a good thing. And that's because we are getting out into the community. We're seeing people where they're at. We're treating a much more complex group of folks. But I think most importantly, what we're seeing is that our PCR positivity rate has plummeted, and we're down to about 14%. And that is despite the fact that we are down out in the community, seeing a much more complex group of folks, people who are actively using. And so I think this is what elimination looks like in Portland. And it's really because of these folks, this harm reduction approach that they take, the way that they are meeting people with love, that they are always down to wait if someone needs to wait, but we will find them again. They keep in touch. We find them in their camps. We find them where they are, and we get people cured. So just, I would say for those of you who aren't doing this yet, or maybe starting small, good. Start small, but don't forget the big picture. Weave a wide net, build these relationships, make sure people know how to find you and you know how to find them, and be slow if you need to, but be sure that people know that they can always come back no matter what. And you can't build these systems without heart or have heart without systems. And you have to remove the big barriers. You have to remove the prior auths. You cannot turn your blind eye on policy, even though you're caring for folks. So thank you very much. I'm sorry I went about a couple of minutes or over, and I will stick around until about 2 o'clock.
Awesome. Thank you, Dr. Seaman. Appreciate you being here. We did have some questions come through, and yes, we can take them during discussion. I'm going to turn it over to Dr. Stacey Trooskin. We'll share some slides here and take it away.
Excellent. Thank you so much. It's such a pleasure to be here with you all today. I wanted to take this opportunity to zoom out a little bit and share with you all some of the experience that I've gained by working with extraordinary teams in various different settings, most recently Philadelphia Fight Community Health Centers, and now the Mazzoni Center, as well as some of the experience that we've garnered by working with other FQHCs through a TA program that I'm involved with called C Change, that's run by Hannah Zellman. And so I thought by zooming out and sharing with you some of the best practices that I've seen implemented, that hopefully we can move the conversation forward and really leverage FQHCs to their fullest extent. Next slide, please. Okay, so to begin with a quote from the great Bob Marley, the first step, and really what for me encapsulates the optimal model of care in FQHC settings, is to open your eyes and look within. FQHCs are really set up to serve high prevalence populations. And if we can start to really integrate routine opt-out screening and build an army of treaters, then we're going to make great headway in being able to move towards elimination. Next slide. The other optimal model of care is to really connect with community partners. So Dr. Seaman did a beautiful job illustrating this, that when you become a hub of an FQHC and you put out spokes and partner with community partners, if you build those connections, the patients will come. And FQHCs can really be a driver of this type of model of care. Next slide, please. So let's start with looking within. Ways to really optimize the FQHCs as a vehicle. First of all, implementing routine opt-out screening. And these models have been built by ensuring that every individual, when they come in for their initial primary care visit, has a HCV antibody screen that will reflex to PCR testing. And that can happen through EMR prompts. It can happen through a first visit order set. It can be built into that first visit or annual exam template where you have to actually unclick if you don't want to order the test or the individual reports already having a diagnosis. But you really want to make sure that everybody is getting at least that one-time screening in accordance with CDC guidelines, and of course, more frequent testing if you're serving a higher risk population. So for example, in an FQHC that serves 30 to 50% of people with a history of substance use disorder, you may want to start just screening annually so that you can catch new cases of infection. We also want to make sure that primary care providers are treating all of their patients. And so creating one-stop shopping in terms of healthcare is really the hallmark of an FQHC, bringing the resources to the patients so they don't have to go other places to receive other types of care is a critical component of this. And making sure that all of your primary care providers are feeling comfortable with treating hepatitis C. It is simple. It is easy to do. It's easier than treating diabetes. And we want to make sure that HCV care is part of primary care. And then the last piece is, in fact, that one-stop shopping model, making sure you're integrating as much services within the FQHC that can support the patient holistically. So making sure you have lab work on site for that phlebotomy and getting testing done so you're not having to refer somebody out to a reference lab. MOUD on site also is super helpful. Transportation assistance to overcome some of those barriers that may impede individuals keeping appointments. On-site medication dispensing, particularly critical in areas where we have to still use subspecialty pharmacies or mail order pharmacies, where individuals who are experiencing homelessness or unstable housing may not have an address for which they can use to receive medications through the mail. So having somebody on site that can log that medication and dispense it from the FQHC is really helpful. Next slide, please. I wanted to give you an example. This was one example of our FQHC care cascade at Philadelphia Fight Community Health Centers. We had over 1,000 patients that ended up being HCV antibody positive between the years of 2017 and 2023. You'll see that of those that were antibody positive, nearly all of them received RNA testing, and that was because we basically stripped our ordering capability for antibody alone testing. Everything was reflexive. Of those that were RNA positive, almost all of them were evaluated for treatment because their primary care providers were also treaters. Everyone underwent labs and staging. We had co-located laboratory services in the lab, and then treatment was initiated on a high percentage of those patients, and nearly all of our patients completed treatment as well. Next slide. I wanted to just touch on some of the barriers to implementation that exist when you're building HCV care just within the FQHC setting. So FQHCs, if you're a full FQHC and not a lookalike, you can receive additional grant funding from the federal government that allows you to really take care of uninsured patients. However, the cost of labs and visits still go uncompensated. So that is a challenge, certainly, and there are ways to try to maximize those resources. Of course, if someone is uninsured and uninsurable, you can often get medication through patient assistance programs that exist through different pharmaceutical companies. So it's possible to do that, but it does also require a workforce to make that happen. There are still provider knowledge deficits about hepatitis C, and making sure that every provider understands how to treat and feels comfortable doing that and counseling patients accordingly is also part of this. In every medical setting these days, there are competing provider priorities. There's more and more emphasis being put on productivity and limiting time with patients. And if you have a really complicated patient coming in with multiple comorbid conditions, it can be challenging to prioritize and move that forward. The same thing goes for patient priorities. There may be something that is at the top of the patient priority: pain, substance use disorder, homelessness. All of those things may be the priority that the patient wants to address in that moment, and Hep C is on the back burner for them. I think most exceptional programs that are built in FQHCs require an internal clinical champion, somebody who really wants to make this their baby and push it forward. It doesn't require a full FTE. It doesn't require someone to have it be their whole job, but there has to be some driver to make this a reality, to get your workflows in order, to be following the data, and to be optimizing all of the patient care around the goal of curing your patient population. There are under-resourced staff issues across healthcare now. I think FQHCs are particularly hard hit. And when you have under-resourced staff or staff shortages, issues around prior authorization can be really stifling in terms of building a program. And so as prior authorization is removed as a requirement, I think it makes it much easier to start to integrate this type of work into already resource-limited settings. And I think it is important to take special follow-up with patients who have missed appointments. And so we do this across all clinical practices. You'll often get a reminder call or someone reach out after a missed appointment. There is a new level of urgency, though, if somebody is on 8 to 12-week regimen and they miss a medication pickup, and you want to make sure that if you have their meds, they get to you. So having a team that can outreach into the community, that can deliver the meds to the patient wherever they may be, whether that's their address or wherever they're staying in community or in a shelter, but you want to make sure that you have a team of folks that can do that and support your most at-risk patients. And I've already mentioned workforce shortages, but even shortages like medical assistants, providers, FQHCs are disproportionately impacted by healthcare shortages right now. And certainly when you talk about growing new programs, that comes into play. Next slide, please. So now let's talk a little bit about if you build it, they will come. And really the idea of a hub and spoke model of FQHCs being the centerpiece and reaching out into community and partnering with community-based organizations that may be syringe service programs, substance use disorder treatment programs, shelters serving people experiencing homelessness, and prisons and jails. The idea here is really to meet those community partners where they are. There may be some locations that are already doing testing. They may already be doing reflexive testing, but then they have patients that they are not themselves able to treat. And so then it's a matter of helping them with workflows to integrate treatment. However, there may be community partners that have no testing capability. Maybe you're working with a syringe service program that doesn't have a lab, that healthcare is not their business, in which case that FQHC can send out testers or clinical staff. The linkage to care piece when you're working with community partners can look different. It can be just providing the lab work. It can mean navigation from that community center into the FQHC. But better and more often than not, what works ideally is to embed the FQHC on site somehow, one way or another, whether that's an extension of the staff or whether it's providers or whether it's just making it so we can provide telehealth services. And I'll give you an example of this. In Philadelphia, there's a very large inpatient drug treatment program. They screen everybody for hepatitis C testing on intake, but they have no capability of treating on site. And so with the FQHC, we were able to set up a model of care where we would send a care team on site that would draw all of the necessary labs for approval of medication and staging. And then we would have that same individual go out and set up an iPad or a laptop. And then we would have a reverse televisit where the provider from the FQHC FQHC would then provide care. We'd have access to all the labs. The medications would be delivered to the inpatient drug treatment site, and it worked absolutely beautifully. So if someone was there for a 90-day stay, then they could have completed their entire treatment course during that hospitalization or admission. So there are lots of different ways to make this work, but the FQHC can be the driver for that medical care. Next slide, please. I want to give you an example of one program in particular, aside from the inpatient drug treatment program I just spoke of, but this is a collaboration between an FQHC in Philadelphia and the Department of Prisons that we built. This was done through the See a Difference program led by Laura Magaldi, and overall the Philadelphia Department of Prisons, which is actually a misnomer, it's a jail, but just unfortunately a very large one, between the years of 2019 and 2022, there were nearly 34,000 prisoners that were seen through the intake. And of that group, nearly everybody was screened through routine opt-out screening. Reflexive testing was done, and of those individuals, around 3,500 were hepatitis C antibody positive. Nearly all of them were RNA tested because of that reflexive confirmatory testing. And then of those that were RNA positive, they saw a provider in the jail that was able to assess them for treatment. The additional layer that the FQHC was able to provide was that there was a linkage specialist that we sent in to the jail for what's called an official visit. And in that time, we were able to provide education for the patient, get points of contact for the patient. So if they were released before they were able to be treated, we would be able to support them in engaging in care. Now, because the Philadelphia jail is pretty progressive and was treating almost anybody that was there for a long enough duration, there were a number of patients that were able to be treated while they were incarcerated, and then we had about another 200 or so show up to the FQHC and be linked to care that way. And so this is a really nice example of a collaboration between a community partner and a federally qualified health center. I think the other critical thing to note that Dr. Seaman also mentioned is that when you have a hub and spoke model in the way in which an FQHC reaches out to community and creates multiple partners, you can often catch folks that maybe have fallen out of care with you at some point in time. So there were a number of individuals that we may have met when they were in the inpatient drug treatment program that were supposed to follow up for an SVR test and then never made it in, but then we found them again when they were unfortunately incarcerated and could assess for cure then. Next slide. So just a quick focus on barriers to implementation, to linkage to care models, cost of labs again. The siloed healthcare system can be very challenging. Behavioral health and physical health have different modes of reimbursement through different payers, and sometimes bringing the two together to make this a sustainable model when reaching out into community-based partners can be challenging. Obviously, there are competing priorities for partnering agencies. You really do need an internal champion in, like, let's say, a Philadelphia jail system to say, no, we want to prioritize hepatitis C treatment and partnerships. Again, under-resourced staff and workforce shortages are critical too. And next slide, please. So just one last thought here in terms of what it will take to really scale treatment in this country by leveraging FQHCs. The first and foremost is policy. I know, again, Andy had mentioned this before, removal of prior authorization is critical. It adds a whole other layer of red tape to the process and requires additional personnel, and it delays treatment. It's a huge problem. De-siloing healthcare reimbursement between physical health and mental health to make those community partnerships a little bit easier is also important. Incentivizing HCV screening and treatment is critical for FQHCs. We are resource limited settings. It's hard to provide care for individuals who may not have resources, and we need to invest in them to support them to overcome the barriers that may exist for care. So it needs to be able to be sustainable for FQHCs to do this work. And then grant funding, having a clinical champion that has some degree of protected time, programmatic staff staff to be supporting the linkage to care, navigation, and retention of patients, and then resources for patient support, meals, transportation, safe storage of medication for individuals that may not have a place to lay their head at night. And then lastly, the technical assistance for integrating testing and linkage to care workflows. And last slide, please. I want to just put a plug in here that C-Change is a technical assistance program to support HCV elimination. We work across policy, education, provide data for programs and help them create infrastructure for monitoring progress, and then with workflow development. And all of this work can happen across different settings as well. And next slide. So in summary, FQHCs can certainly serve as a hub and spoke model for cure that provides access to primary care and preventative medicine. It's a safety net by design. So the lack of referral needed when folks are coming in sets individuals up for success and really creates a low barrier setting. There are often additional integrated services on site that can serve the patient holistically, like substance use disorder treatment. And we're serving high prevalence populations. So you get a lot of bang for your buck when you invest in FQHCs to do this work, but it has to be an investment. Ample financial support is needed to be able to make this sustainable for FQHCs across the country. Thank you. Thanks for your time.
Thank you, Dr. Trooskin. Questions are still coming through. If folks want to continue adding to them, we'll hopefully have some time for the live discussion. I'm going to turn it over to Dr. Stephanie Constantino. All you.
Hi, everybody. Thank you so much for having me. And aren't you all just so inspired by all the amazing work that is being presented? It's so exciting. I am just so honored to be on this panel. I am here instead of my mentor, Dr. Christian Reimers, which you probably already know. And I will be reiterating a lot of these major themes around FQHC, hepatitis C screening and treatment that are unique to our San Diego communities. So thank you so much for having me. Can you do next slide, please? So one of the unique things about FQHCs, as Dr. Trooskin alluded to in her presentation, is that really FQHCs are a one-stop shop. There is a no wrong door policy when it comes to coming in for hepatitis C screening and treatment. At Family Health Centers of San Diego, we have more than 35 clinics, including mobile unit sites all across San Diego County, and they can enter through primary care, through mental health, through substance use disorder services, hepatology, we have OBGYN, we have lots of services everywhere, surgery exchange services, and at any point in time that a patient encounters our system, they can be referred into treatment. Next slide, please. So hepatitis C services at Family Health Centers started very similarly to what Dr. Seaman was talking about. And if there's like one major takeaway, I think, from this presentation is that if you have an internal champion, like a clinical champion, like a Dr. Seaman or Dr. Trooskin, or in our case, a Dr. Reimers, you can really, and all of you attending right now are potentially those champions in your communities. You can really spawn an entire treatment program. And so it's really started off as Dr. Reimers recognizing a need in our community and saying, okay, let's get a grant, let's build up our internal capacity and train primary care providers to be the one-stop shop to learn with confidence to evaluate and treat hepatitis C. And this was in the advent of new introduction of DAA, so it was getting a lot easier to treat hepatitis C as well. So we have a well-established clinic-based hepatitis C program. We've grown now. We have 4 ID specialists and 11 primary care hepatitis C treaters across 6 different clinics. Our team also includes hepatitis C navigators, a transplant hepatologist, sonographer. We have 2 clinic-based fibroscans and 1 shear-wave elastography. And we, pre-COVID at least, and we'll probably be reinstating this soon as well, we had echo modeled meetings, which really helped to enrich our training and to give primary care treaters a place where they could bring their cases and really learn and build confidence around their treatment of patients. And we also had people calling in from other FQHCs and rural treatment programs as well. So that was certainly enriching. We've also started a mobile medical unit in the last couple of years. With the sites that we park at include homeless shelters. We park right at 60th and Imperial, where there's a lot of tents on the street, as you saw with the opening photo. That is a picture of right outside our mobile unit, where people are actively using or withdrawing, overdosing, you have it. And we partner with Clean Syringe Exchange Program, which has been around since 2001. So it has a well-established community trust, and we partner with them and park with them to offer services. So on the mobile medical unit, which I'm on the unit about once a month or so, we have rapid hepatitis C screening treatment. We have a FibroScan on board. We also offer low barrier buprenorphine and wound care. And so all those are ways to engage our patients. And we are able to basically screen them, get their FibroScan, get their whole history, and then write their prescription. And then they come back in 1 to 2 weeks to come pick up their prescription right there on the unit on Tuesday nights. And so that's basically the workflow that we have at our mobile medical unit, and we park at various locations in San Diego. Next slide, please. Okay, and so this is a picture right outside our mobile unit where we are on Tuesday nights. And so I think if we're really going to push FQHCs to being able to expand screening and treatment, we really need to meet people where they are. And a lot of that includes going to the tents and recruiting the patients. And we have a street outreach team that goes and does this, and building trust with the community so that they feel like they can come to you. Trust is so essential when we're talking about working with communities that have been disenfranchised or marginalized or have been heavily stigmatized and mistreated in the medical system. We're talking about patients with addictions and or feel stigmatized by their Hep C or HIV or what have you. And so I think if we're able to go to the streets more and backpack out to where they're camping and really get to know them and help support them in other ways, and we meet people where they are, they're more likely to come in for screening, for treatment, and get their cures. So next slide, please. So this is the peek inside our mobile medical unit, and so you can see the outside, and our treatment team includes our medical assistant, Ignacio Aguilar, who is amazing. He will actually go and track down the patients. If they miss their appointment, he will go and walk and find where they are, where they live. He'll even go and deliver the medication to them if they miss their appointment. And so he is fantastic. What a great human. Kelly, our PA, Kelly Rimble, actually came from Philadelphia, really wanted to see Dr. Trooskin's presentation, but wasn't able to make it today. But she is a rock star, and she's on the unit a lot as a provider. And that's a picture of her doing the FibroScan right on the unit. And we have our phlebotomist, our CPT, Jorge Cazares, who is able to get the labs that we need right there on the spot. Okay, next slide, please. Okay, so some key elements for our success, and some of them have already been brought up by our other panelists. So we really want to look at, go ahead and click. I thought it'd be more dramatic and great if we, oh, good, yes, revealed each one by itself. I think we're really special and blessed in California state because we have policies that lower barriers. So we don't have prior auths. And we are using the simplified treatment algorithm. But, we didn't get there by mistake. It really took years of dedicated physicians like Dr. Ramers going to our state capital, going to Sacramento and saying, this is what we need. We shouldn't have to determine, they don't need it to be, totally clean from drugs. In fact, they're very good at taking drugs every day in a timely manner and can be cured, and showing them the data and advocating for lower barriers for treatment. And so I think we're very blessed in California because we do have a very progressive state government that is supportive of that. Next slide, next Next click, please. Yes, community partnerships. And this was illustrated also by Dr. Seaman and Dr. Trooskin. Communities are so important. It really takes like a village to cure all the hepatitis C, right? And so you want to build rapport with your syringe exchange, your harm reduction services, your homeless shelters, your other treatment programs, residential treatment programs, other community health centers. And I think when we share that mission and that values-based approach, we build partnerships, friendships, and then we can all be resources to help each other out. And so I think that is also huge. Okay, next slide. Next click. Yes. I mentioned this before. We have a great supportive FQHC leadership and staff, and our clinical champion is Dr. Christian Ramers, and he really pushed for growing our internal capacity for treating hepatitis C as primary care providers. And of course, our amazing providers, navigators, substance use counselors. I've never met a more dedicated group of people who have like the kindest compassion hearts ever. I really think that this work is really phenomenal. And I'm just so happy that all of you are here working on this issue. Next. Primary care capacity next. So part of the primary care capacity, which I think is unique, and that's something that I get to bring to this forum as well, is our family medicine residency program has an HIV track. And in the HIV track, which I did as a resident, I graduated in 2018, you also have to learn Hep C, and you also have to learn buprenorphine, and you also have to kind of learn gender care too. And so with this treatment track, we are able to grow internal capacity and confidence in treaters. And we're graduating 2 to 6 brand new treaters every single year. And I think it's a phenomenal thing. And I think that's an aspect that FQHCs could certainly look at doing more, is growing their own family medicine or internal medicine residency programs through the THCGME program in order to build internal capacity and people who stay. And historically, percentage-wise, a lot of our graduates do stay, because in no other environment do I get to work in such a diverse group with such a wide scope, and with the support of infectious disease doctors and a company and a FQHC that actually will provide the things that my patients need in order to get their treatment, right? So I think that is something that is unique to our program here, and hopefully that can spread as well. Next click, please. Yes, and of course we can never do it without funding. So funding and grants is so important. We're lucky because we do have a grants department that helps us write grants, and we've received funding from CDC, CDPH, from industry, pharmaceutical partners, and of course from 340B as well. And so funding, of course, is an ongoing struggle for FQHCs, but we've been so lucky to be recipients of some really excellent funding. Okay, great. Next slide, please, finally. Okay, so some challenges of an FQHC has been alluded to before. So we do have uninsured self-pay patients. We have high clinical productivity demands. We have shorter visits. It's like, what can you do with a patient who has like 3 or more failing organs and 20-minute visit and was just in the hospital for like 100 days? Like, that's just so insane, right? And you have to do all of these different things in a visit, in a primary care visit. So there's definitely some competing interests as a primary care physician. Funding streams and consistency of funding streams is really important too. I just recently learned in this last year that AOD counselors cannot bill for their services. They're all grant supported. So I'm just like, oh my God, what happens if the grant dries up? Like, we really need this AOD counselor. It's so crazy. So maybe we can look at changing the way we're able to like bill and receive money for the services that are actually provided as well. We do have a pretty high staff turnover. That's really unfortunate. There's so many different reasons why. I mean, we come out with so much debt as clinicians, as physicians especially. There's a lot of different private organizations that can pay more. There's so many different reasons for staff turnover, and that could just be a whole lecture in itself: moral injury, burnout, etc. Socioeconomic barriers, of course, poverty for our patients, housing, transportation, phone access, health literacy, food insecurity, safety, and justice-involved issues. Those are all barriers that we face, and we can kind of chip away a little bit by providing a little bit of services. But I think that definitely gets to to the crux of our patients at FQHC, the barriers that they face and what we try to do for them. Next slide, please. So as far as future directions go, next click. So we're about to get a grant for rapid Hep C confirmatory testing, and I'm excited to maybe do what Dr. Seaman's doing up in Oregon. Next slide. Next click. We're going to continue expanding mobile medical unit services and potentially street medicine as well. Next. More collaboration with harm reduction programs, community clinics, pharmacies, nonprofits, and jails is the next real partnership. I think we're going to try to grow that pipeline a little bit more. Next. More collaboration for treatment capacity building. So we're going to reinstate our ECHO and potentially even try to help expand primary care residency programs. I was at the California Society of Addiction Medicine conference last week with the MRF group, and there's so many different residency programs that want to build tracks, like a Hep C track. There's huge interest in expanding this, so I think that that's an area we could also build up our capacity. Next. Hope telehealth is here to stay. That's a future direction I want to keep fighting for. Next. Universal EMR, that would completely change our lives, I think, and that's something I would want as a wish list. Next. And of course, my ultimate wish, which would be a single payer system. Can that be our future direction? That would be amazing. Okay, next. And I think that's probably final. Thank you so much for your attention. And I actually have like 28 seconds to spare, which is lovely. Thank you everybody so much for your attention, for your passion, for being in this work, and for allowing me to be on this panel. I hope to connect with all of you. And please reach out to me if you have any questions. I'm here as a faculty physician on the Family Medicine Residency Program and would be happy to collaborate with you at any time. Thank you so much.
Thank you to all our speakers for such excellent presentations and really sharing a whole lot of wealth of information of what are some of the successes, what are some of the barriers that are happening at FQHCs, and what needs to be done. Before we go into the question and answer sessions we see that some of the folks have been writing some questions in the Q&A box. I just had a twofold question. So one is I wanted to actually ask all the speakers, what effective strategies have you all utilized to really engage and retain patients in care who are coming at these FQHCs? And then my other question, which is really based on, briefly mentioned about telemedicine services, how are that being utilized for hepatitis C care? Like, what are some of the challenges in relationships, maybe perhaps to appointment reminders or medication management or anything that you all have encountered, if you all could speak to that. So I guess the first question, a little bit more on how are you all engaging and retaining patients in care?
I guess I'll go first. That way nobody can steal my answer. I'm kidding. So I think it's huge. Like, building trust is huge, and building that patient rapport is huge. I find that if a patient feels heard and trusted, or that they feel trust with their provider, they'll come back. Even maybe they're not so ready to get clean or sober right now, but they'll remember you and be like, you know what, Dr. Constantino was really cool. She made me feel like I could come back anytime, not judged for my ongoing substance use. I'm going to go back to her and get my Hep C cured. I've had tons of patients come back to me after years. They're like, I wasn't ready back then. I'm ready now. And I love that. And I think that's one way we can retain in care is to encourage people to build that rapport.
I think that's exactly right, Stephanie. I think if you create an environment that's non-judgmental and engaging, that folks will come back when they're ready, if they're not ready at that moment. I think another thing that we can do, aside from creating that environment, is to also plan for the worst and always work towards the best. And one thing that we found has worked really well is getting multiple forms of contact for patients, not just an emergency contact, not just their phone number, but being really creative in understanding where somebody may be staying, even if it's not an address, but where do you get your check cashed every month? Where would be a good place to find you? Where do you hang out? Where do you have your mail sent? Those things work really well. And then also upfront, again, plan for the worst and hope for the best, but figure out where would they feel comfortable meeting with us? Can we go to, this particular place that you've told us that you've hanged out, and try to find you, or bring your medicine there if we haven't found you? But do your best to set yourself up to meet the patient wherever they are at any moment in time, and not be scared to go the extra mile to get them their medication, or to reach out to them to meet them.
Absolutely. Yeah. So I would echo all of that. I think, we've given a talk at INSU about, love, human interconnection, interconnectedness, harm reduction as sort of the cornerstone of elimination. And I think it really is down to that. The people who are really doing the work it's not our providers. It's all of these outreach workers who all have, lots of different experience. One of the people who works with us now got treated by me 5 years ago, something like that. And now she's out there on the street in the OTP, in camps and all of that. And people get that, and they feel really comfortable saying like, hey, not right now. And I'm like, all right, great, no problem. And like you said, Stacey, like, it's not just, your address or your phone number. It's like, where's your camp, and we'll just roll on down to their camp, and we might run into them there. And then again, it's all the other organizations that not only have to kind of know you exist, but also know that your patient might be involved. And so when someone in the community hears Hep C, they think about you and your system, and they know to just reach back out, and they know that you'll treat them no matter what, and there are no limitations. And that's all really key. Other things that are really important: people who don't have cell phones, we give them cell phones. People who are once they're diagnosed, if they have an RNA positivity, we will give them a cell phone that we hope that they give back to us at the end of their treatment. But if they don't, then they don't. We're not going to punish you for it. Try to find ways to get people into housing, is really critical. It's so hard to care about Hep C when you're trying to think about the toe tap at 2 a.m. And so there are a lot of things. Text over calls always, if you can. A lot of people don't have minutes, but they have like a free text service is much more useful. And, again, just people knowing that they can always come back. If you looked at our kind of cascade over time in that last graph that I showed, almost everyone diagnosed early on eventually we got. But many of those people, it took a year and a half, 2 years, and we hear those stories from our team, and it's a beautiful thing.
Thank you for that. I also know we have some other subject matter experts who are invited to be a part of this conversation. So if you all want to chime in, turn on your webcam, join the conversation, please feel free to contribute. I did see some questions come through that were directed to our presenters. Also, Dr. Seaman, I know you have to jump off early, so if I may direct this to you. It's from Jan Diamond. How did you fund the money for incentives? It seems to be a challenge when it comes to grants and, even within health departments, what you can and cannot do. So can you speak more to that, please? And you're on mute.
You would think with all this time on Zoom. I'm glad you brought that up. If you are an FQHC and you have a pharmacy, you likely have a 340B pharmacy. So many programs fund their Hep C work through pharmacy revenue. You do generate funds from every person you treat. And because the meds are still so expensive, but they're much cheaper, and they're cost effective and they're cost savings even, they do generate a lot of funds. So a lot of this was demonstrating how important this was to our organization and to the other work that we do, that they were able to see the benefit of really small incentives that can make a big difference. And it's really a sign of respect for the people that we serve. If someone has to make a decision of whether they can, like for 3 hours or go and get their lab work done, and if that's going to make the difference of them being in withdrawal or them being hungry or not having a place to stay, they're going to choose the thing that's going to let them have a place to stay. And so giving someone an incentive is you're not coercing them. You're just trying to say, hey, look, we respect you enough in your time, and we know you have these trade-offs. So I think initially it was through that. We have done some investigator-initiated grants to kind of show proof of concept, including the Gilead Focus Foundation and others. They don't pay for incentives, but they do kind of offload some of our other costs, and then some other grants that have paid for incentives to show the proof of concept. But I don't think that's necessary for most of you who have pharmacies. The Hep C treatment revenue himself is it very, very easily pays for the incentives.
Colleen, I saw your hand raised, so if you'd like to chime in.
Yeah, thanks, Jasmine. So a couple of things I saw in the chat regarding working in the jails, and I know Dr. Trooskin had mentioned this as well. One thing in New York State, and I think also in California, is the 1115 waiver is a great vehicle for getting sustainable services in place. And I know in New York, there is a piece of our 1115 waiver, actually, I think it was pulled out of the larger waiver, that will allow healthcare services to be provided. I think they're going to look at 90 days prior to someone's release from state prison and from local jails. So this will allow that sort of warm handoff, relationship building to actually happen within the jail, within the prison, although we do have some work happening in the state prisons in New York State now. But to have a provider at least do the pre-treatment assessment, to maybe get prior authorization done. And so when the individual is released from the correctional facility, they can continue with that particular provider throughout the course of treatment. Another thing that we have done in New York State, I know folks had mentioned telehealth, is again, telehealth is great to be able to begin to establish that relationship. And so we have partnered hepatitis C providers in community health centers, in hospitals, with some of those other high-risk settings, so that, again, they can have an initial telehealth visit, say at an addiction treatment center, to start the conversation, to do a meet and greet, to draw pre-treatment labs, get all of that work done, so that when the individual is released, they have an appointment, and the navigator within those programs can continue to make that connection to make sure that the individual makes that first appointment, starts treatment, and then completes treatment.
If it's okay, Jasmine, I was just going to add, thank you. These were all wonderful talks. It's great to see some of you again, meet Dr. Constantino. I think the FQHC aspect, like the theme of this, having heard the jail talks and the OTP talk yesterday, I think the thing that's amazing and wonderful to me is that there's such a wealth of knowledge, and so many people have figured out how to implement this where they are. And I think the thing that's unique about FQHCs is, as primary care providers, as providers, especially, I think, hopefully in the last few years, really invested in substance use treatment. I think we're so well poised to integrate this care, and I think the things that Andy and Stacey touched on, like being able to routinize and make it as easy as possible for the people in your FQHC and your patients to like make it approachable and accessible to people wherever care is being delivered, but having that driven by a champion or navigators like that, at least for us. I'm sorry, I'm Maggie Beiser, I'm a nurse practitioner at Boston Healthcare for the Homeless Program. I think that aspect of this, wherever these programs are being implemented, is sort of central to the FQHC success. It's like, make it as easy and engaging for everyone as possible, while also having someone with like really important, diligent attention to whatever that FQHC needs, because everyone knows what their patients and their community and their colleagues need to get this to be done. There's no like one size fits all. And I think it's awesome to hear how people have made this work for their various places.
Thanks for that, Maggie. So I saw some questions come in. I think we're just going to kind of try to bring them one into the next. So there are questions. We already answered the one about incentives, but there's other questions about money for phones, money for transportation. Emily brought up this point, so the Family Health Centers of San Diego has unique supports for this work, including champions such as Dr. Ramers, a broad array of services beyond primary care, substantial resources. So I think for everybody, what tips would you give to FQHCs that don't have the same level of internal championship and resources to improve their work related to HCV?
Well, we have to start somewhere. And the good news is you are the champion now. Like, you may not feel like a Dr. Ramers or a Dr. Seaman or Dr. Trooskin, but you have to start somewhere, and we're all here to support you. And so I think ECHO is a great format where you could start joining and learning more about it. Anybody can read treatment guidelines, go to the HCV guidelines, learn them. The simplified algorithm is there. Use the Liverpool Hep C drug interactions thing. Ask us if you have questions, present your cases, and you become the internal champion. We're here to help support you. And so I think I would challenge everyone to try to be brave, to be like, I can do this. I don't have to be an ID trained MD. I don't have to be med peds from Duke or went to a fancy university. Like, I am the champion now, and I'm going to push this. And I'm going to get the support from the people who believe in my work and can help support me clinically, and also internally. Find your partners, your advocates, the people in leadership who believe in your cause. And I think you will find that you will become a fantastic champion. And I've got to grow in a little bit to a mini champion myself. Here I am on this amazing panel. And so we're here to help support you. You're going to become the leader that your organization needs to become a champion.
And I'd advocate again that, if you have to think about what the people who are making these decisions at your FQHC care about, and some of it is mission, and absolutely that is a big driver, and some of it is financial. And so if you can figure that out, and I know that a lot of other people on this call have done that, again, if you have a pharmacy, that is a huge incentive for them to put resources into this. So figure that piece out if you don't have it, and that can help open up the doors quite a bit to do a lot of experimentation and do things that aren't for themselves reimbursable, like cell phones and so on.
I put in the panel chat, but also just to mention, state departments of public health sometimes are very motivated to fund this work, and that's about relationship building as well. We have our Ryan White HIV program has state and federal funding, and in the last procurement, they carved out an individual line that paid for Hep C services, kind of however we imagined them. And so we said, we want to pay for navigators. And they said, cool. And so we don't have any, we do have a small 340B revenue from just our Medicare patients, not from any of our Medicaid patients, which is a very small thing, and does not go back to our program, unfortunately. But this state relationship and state funding has been really central to our growth, just as an alternative option.
Just to piggyback on what Maggie said, state health departments all have a resource for viral hepatitis. And there's a lot of us on the call today. And, one of our roles is to build capacity and to provide technical assistance. And I think all of the presenters today highlighted some of the barriers and the challenges. And I know one thing that we see as a barrier in New York State is that workflow of getting the client through the door, tested, diagnosed, and on treatment. And so we're working on designing some tools for community health centers and healthcare facilities as to what that workflow might be. And so I really encourage folks, putting a plug in for my colleagues in other states, really to call upon your health department viral hepatitis programs to provide that help with capacity building and addressing some of those challenges that programs might be dealing with.
Cody, I also saw your hand up, but from the perspective of the state health department.
Yeah, sure. I was just going to echo Maggie's point. I think getting in touch with your state health department folks is a great idea. And this conversation has been really interesting to follow as somebody who sits in a state health department, really at the intersection of HIV and viral hepatitis, where we've really worked to leverage longtime well-funded infrastructure from our HIV work and leverage that to support our hepatitis C work. In Iowa as well, we also leverage our relationship with the state's primary care association to provide technical assistance and support to all of Iowa's federally qualified health centers. And Dr. Trooskin, I took some notes during your presentation, and several others as well, but talking about the challenges with identifying champions and with workforce retention within FQHCs. I would just offer that we've been successful by funding positions within our primary care associations to act as champions across all of our federally qualified health centers and supporting the development and implementation of workflows in a wide variety of settings by being able to provide or to fund 1 or 1.5 FTE that are really stable within the professional organizations that also provide all the ongoing technical assistance and coordination and data analysis and monitoring, and have worked with our sites to get them all in the process now of migrating to centralized EMRs across Iowa's federally qualified health systems, or health centers, excuse me. And we've done that by braiding our funds between hepatitis, which are very limited in the state of Iowa, with our more robust HIV funding, and are addressing implementation of routine screening for HIV and viral hepatitis together across all of those health centers. Our primary care association, through that funding, also convenes and coordinates our ECHO project, and provides that sort of spoke linkage to all of our other services, like our harm reduction service organizations, our centralized prevention navigation services. So I think there are ways to really engage with and leverage your state health departments. And for those of you who aren't SDOH folks, I would encourage you to get in touch with them. And for those of you who are, if you're ever interested in talking about how to leverage your relationships with your primary care associations, we'd be happy to chat with you.
Thanks for that perspective. Go for it, Maggie.
I was just going to mention, if you can count it and share the data, people will listen, has been my experience. If you know what the size of the scope of the problem is, there's a lot of, I think, energy and excitement. And even if they say, right now we're not sure how we're going to make this work, at least you're coming with information that will help drive agenda as time goes by. I think no other area of primary care or even HIV care has been sort of as exciting in terms of flexibility and like creativity with how viral hepatitis work can be implemented.
Thanks for that, Maggie. I do think, data can be its own language, like as a catalyst for change, but this actually feeds into Vinny's question here, asking about any electronic health systems, platforms, softwares that are easier to navigate for people that are working in the street outreach setting. And they're coming from this perspective of community organizations that focus on street outreach who are without clinical staff, without clinical services. How can you share patient information that supports privacy, but ensures that the intake process into the FQHC clinical setting is as frictionless as possible?
I can add this, that it's not necessarily EMR related. I think, well, let me start here. So when we've had teams that have gone out into the community who are affiliated with the FQHC, we often will have, it works best when they document touches of patients, whether they're phone calls, visits, whatever it is, on the street in the EMR, so that way the treatment team can see what's happening, and we can pick up seamlessly where the navigation team has left off. For organizations that may not be affiliated with a clinical environment that have an EMR, there are other ways that you can leverage technology so that information can be shared. So one thing that we've done on the ground in almost every environment that the teams I've worked with have been in has been to leverage REDCap, which is Research Electronic Data Capture, and it can be shared through multiple different organizations. It can be set up as a survey, and only one side can see the back end. But if you have a BAA or something in place to share protected health information, you can then set up something like that to create seamless linkage to care with data from community into FQHC or clinical setting. And so something like that can be really leveraged to create shared information so that patients don't have the frustration of like, I already answered these questions like 20 times and now you're asking them again. So that can be something that's done. We've sent our teams out into the jails with them, into the community-based testing models. We've used REDCap in a lot of different settings. And, I'm happy to speak with anybody who's interested. I'll volunteer the other folks that I've worked with, Laura Magaldi at See a Difference, at Philadelphia Fight. Hannah Zellman has used it as part of Sea Change. So there are lots of examples that can be drawn from.
And Stacey, I really appreciate you bringing that up. I think REDCap is a really good solution, and we haven't actually used that, but we'll explore that. Another thing you can do that's similar that helps you navigate not only the information sharing piece, but also some of the ordering pieces is what we've done with opioid treatment programs. So we started using dried blood spot in now 5 different, I think, 4 or 5 maybe fully implemented opioid treatment programs. And that's been a huge game changer for us. I think DBS has a lot to offer for that setting. So these are, for those who don't know, OTP is really a methadone clinic typically. And everyone has to get a syphilis test by federal regulations if you go into an OTP. And to the extent that if the person that they're serving doesn't get their test done, usually done by phlebotomy and usually a send out, someone has to go to an outside lab, they have to take them off their methadone, which is a huge problem in a lot of levels. Dried blood spot that we use, you can actually do syphilis testing on dried blood spot as well. So it incentivizes OTPs to start doing this. And since we've implemented dried blood spot, Hep C, HIV, Hep B screening at these OTPs, all of them have gone from essentially 0% or very low percent Hep C screening to essentially 100% Hep C screening in all of these OTPs. Their staff are doing it on their own. But one of the ways we've done this is that we have navigated the complexity of setting up the relationship with the lab. And that's molecular testing labs in Vancouver, Washington. We don't have a financial relationship with them, but we did help them validate their test. And so we will set up the relationship with the lab. We will set up a business use agreement with the OTP and us so that we can order the tests and see the results. They can order the tests and see the results, and we have shared visibility on that. And each of these health systems don't have to do the work of setting up the relationship with the lab. We do that ourselves. So you kind of take a lot of the burden. That's one way you can take a lot of the burden off of community partners and also maintain visibility between lab results.
Thank you. Thank you for this great discussion. Then we have one more question from Maria, which basically asks on how do you establish hepatitis C testing, treatment, and harm reduction programs in jails and prison systems where privately contracted providers are already present? Often these contractors do not wholly understand the unique issues of the clients who use substances. And how are you making roads with prison leadership to create your programs?
Can take that as a first step. You have to make friends. You have to introduce yourself and go in there. They may not know they want to hear from you, but they do. And so you have to find those internal champions. And that can happen at a bunch of different levels, both at jail or prison administrative levels. It can happen provider to provider, but we've done all of those things, and we've provided education to their clinical staff, everyone from the medical assistants. We did many years ago a presentation for the correctional officers that were there. There was a lot of misinformation about hepatitis A, B, and C. And so if you're going in offering free service, which is education, support, linkage after release, then you've made yourself valuable. And so you can start to make inroads and then start to make the case around why testing, treatment, education is important. And so it's really about relationship building. It doesn't happen overnight. You have to create trust, but they're relationships worth having.
I feel like it's also important to say that we sometimes forget we have built such accommodating systems around something that should be different. Like we should just be able to treat everyone who's in jail or prison while they're there. And I just want to say that out loud because I think it's an important thing that the 1115 waiver, the relationships are critical to doing as best we can right now. But there's a much better way to do this too. And so I think driving the agenda is it's important to consider all of the range of things that we could do.
Thank you. Does any of the mezzanine panelists have any questions or would like to highlight any points? No? All right, great. So thank you so much for this panel, for a great discussion. We learned a lot about, some of the successes, some of the barriers, and obviously financial barriers as being one of them. But we also learned a lot about the importance of championships and how do you build trust, leverage partnerships with not only the state and local health departments, but also with the primary care associations and pharmaceutical companies. So thank you so much. I really appreciate this session, and I will now hand it over to Jasmine for the next piece.
Yeah, so with that, we are going to move into a break, but again, a virtual round of applause for our presenters today, our subject matter experts for their contributions. As a reminder that this is being recorded, slides will also be circulated, and then that final report that will synthesize, best practices that we're teasing out between yesterday and today's sessions. So stay tuned. We will reconvene at 2:30 p.m. Eastern time. So thanks to everybody, and we'll see y'all shortly for the next session.